talk to me about what a sound disorder is.
So in my practice, I work with kind of a big variety of kids. Some of them were just really simple articulation errors, kids who have a lisp, kids who have maybe just a problem with one particular sound like R or L or S. Those are some of the common ones. But then I also deal with children who have phonological delays and disorders where they have some patterns going on in their speech. They're maybe dropping the same sound off all the time or replacing it with a similar sound all the time. And so I deal with phonological disorders and delays like that, where kids are much more difficult to understand. And then also speech, motor speech disorders like childhood apraxia of speech. And so that's basically speech sound disorders run the whole gamut from mild to severe. But it's just about production of speech sounds and the intelligibility, how much you can understand of what a child is saying.
And I think sometimes parents get confused because as speech therapists, we throw the word around all the time, intelligibility, but it doesn't refer to a child's intelligence.
No, and this is true. I even had my sister-in-law ask me, what are you saying about my child? I said, oh no, that's not what it means. It just means to what extent can a stranger understand what your child is saying to them? Yeah,
which is so important.
Yeah,
so important. But can you just tell us a little bit about apraxia? What does that have to do with the mouth?
Well, it's a neurological based speech sound disorder, which does not mean there is anything wrong with that brain necessarily. I think that word kind of freaks people out when we say neurological. It just means, my good friend Carrie Ebert says that basically that just means that the speech starts in the brain. And because you have to formulate what you're going to say, and then you have to activate those muscles to work in the way that they're supposed to work in order to make certain sounds. And so there's some kind of a glitch from here to here with children who have apraxia. So these are kids who have very inconsistent errors. They have difficult with prosody and rhythm of speech a lot of times. They'll have trouble with vowels. So there are certain markers that apraxia has that other kids with other types of speech disorders will not necessarily demonstrate.
And, it's interesting you should bring it up too, because, I specialize in pediatric feeding, and I definitely work with children who also have that apraxic element to the way that their mouth functions. It's sometimes very tricky for them to move their tongue in a certain way or to chew in a different pattern. They get kind of stuck on one pattern. And so the thing to remember, especially for those parents joining us, is that the mouth function itself is what we often focus on. But one of the first things we do as speech language pathologists is we look at the structures themselves, and then we branch out from there. So that's what we're going to do today. And Amy's going to get us started with her awesome oral facial exam. And again, I'll put the link here in the comments in just a few minutes where you can download that. But go ahead, get us started.
Sure.
Light us up.
I'm just going to kind of go through this checklist here. I don't know if you can see it very well, but it's basically the bulk of the exam is 2 pages, and it's kind of a simple checklist style, or you just kind of circle the correct answer style assessment.
Well, but I thought, no, wait a second. It's only 2 pages for the actual exam. So how long does it take?
Well, I have to say this is probably the easiest exam an SLP could probably give, as long as you've got a cooperative child with you. It can take as little as just a few minutes, 5, maybe 10 minutes max, depending on how cooperative and how you have to maybe coerce the child into cooperating. You might have to make it more playful.
We're good at that.
So yeah, that's one thing we're good at. It's that for sure.
But it's not just a 2-page download, because a little bit hard to see here, guys. I'm going to, again, we'll get the link here for you in a minute. There's actually, gosh, I don't know, 4 or 5 other pages that's nothing but information.
Yeah.
So I can show that to you. There you go.
Perfect. As even past that page too, there are sections basically kind of giving you a little bit more instruction and guideline on each individual structure that you're going to be assessing. And so even though these 2 pages might have, ask them, look at the symmetry of their face at rest, look at their tone of their face at rest. And you might say, well, it looks a little hypotonic to me, but now what? And so the other pages kind of go into how to interpret those findings.
How to interpret it. Yeah. That is great. Yeah. Well, let's get started with our oral facial exam. We've got our throat scope so you can see.
I do. This is the throat scope. Oops, dropped it.
That's okay.
Liz. Can you grab it, sweetheart? Thank you. I know I grabbed it. So this is the throat scope that I love to use, and I'll demonstrate this in just a minute. But the first thing that the oral facial exam looks at, or has you look at, is just kind of observing a child's face at rest. So you're looking to see if there's how the tone is, if there's hypertone, hypotone, low or high tone. I'm looking for mouth breathing as well. A lot of times if I have children who have lisps, and I notice that they come in and their mouth is kind of hanging low in their mouth and their mouth is open, they're not really breathing through their nose.
More this way.
Exactly.
Carrying their tongue a little bit more forward.
Exactly. Then that's going to cue me to ask even a little bit more, maybe some more questions in my case history with parents, talking about, are they snoring? How is feeding? Is it kind of messy eating? So lots of indicators that can help me look at too.
Sure.
Then she's not mouth breathing, so we're good. I'm going to circle WNL on my form. Her symmetry looks good. Her tone looks very typical. So those are all within normal limits on there. Now I'm going to look at the jaw. So let's open our mouth, open our jaw really, really big and close it. And I'm looking for any deviations to one side or the other, any limited movement. And then I'm going to ask you a couple questions. So what is your favorite subject in school?
Literature.
Literature. Why do you like literature so much?
Because I like to read.
Oh, you do. So
Yeah,
that was a good answer.
That
That was so good. And so, yeah, I know. And you're good at it too. And so the reason I like to kind of get them talking a little bit, for one thing, is I want to know more about the child. But I also want to observe that jaw movement during speech as well. So and your jaw looked pretty good. I didn't notice any big jaw sliding happening. So that's all I'm going to mark with the normal limits on there. And then we're going to look at dentition, and I have a whole section on dentition. So I'm going to ask you to kind of close your mouth and smell really big. And what I'm looking for there, I'm looking to see if there are any class 2 or class 3 malocclusion. So like underbite versus an overbite.
So malocclusion is basically where, in simple terms, where the teeth just don't line up the way they're supposed to.
Yep. And maybe I can show you this too. If you have, like me, you have a hard time remembering, I don't know if you can have it. I have some diagrams on there so you can actually see what that malocclusion looks like.
Oh, right.
There's
right here.
Yep. There's the overbite, underbite. Yep.
There's so much information on this. It's great.
I tried to make it as easy to use as possible, where you really just need to refer back to the guidelines if you have any questions.
Right.
So, and then we're also going to look at the incisor occlusion. So is there an open bite? And that's another thing too. If I have a child who comes to me and, mouth breathing, the tongue is low, see if there's an open bite. And then I'm going to ask the parents, is there any thumb sucking going on? Any pacifier use? Because a lot of times those are correlated. So that's one indicator. And smell really big again. I don't see any of that. So I'm going to circle within normal limits for dentition as well. And
this really goes quick.
Really quick.
We're spending a little bit of extra time just explaining it, but it goes with 5 or 10 minutes.
And a lot of times I don't have to have them do a different task for each section. I can just say, okay, well, I've already asked you to smell big. I'm going to mark off dentition. I'm going to mark off occlusions. I'm going to mark off there's no teeth missing. There's no orthodontia. So just with one task, you can just check, and move on down the list.
Great.
So the next thing I'm going to look at is the pharynx, so the throat basically, and that's where our handy little throat scope comes in. And this is the best thing ever. I've had this I think I bought it, I don't know if it was the first time they were at ASHA, but I bought it a couple years ago when ASHA, or the American Speech Language and Hearing Association, was in Los Angeles. And I've used it ever since with all my oral facial exams. And so basically this is going to click on and it lights up.
I'm going to turn off this back light so all of you can see a little bit better.
And we're going to try to get this as good as we can. So I'm going to ask you to stand up, Linz. Okay. And I'll try to not make this awkward. But open your mouth really big for me. Can you look up to teeny little bit?
Wow.
A teeny little bit. Let's see if I can get this inner mouth a little bit. It's hard. Kind of
really lights it up.
This way. Look down a little bit. Now say up a teeny bit. I'm going to try to move it out. Say ah really loud. And this is a lot easier when I'm in the front. Look up a little bit. And you can see the soft palate. And what I'm looking at, you can't see because I think the lighting is a little off just with the video. Yeah. But in real life, the entire oral cavity just lights up. And in the past, I've had to get my camera phone and turn the light on my phone. I'm trying to hold the tongue depressor and okay, wait, say again. You know, it's so awkward.
I don't like it either because I'm holding my dirty phone.
I know.
Yeah.
I know.
like having the fact that I've got, first of all, a tongue depressor. This starter pack comes with an extra depressor on the back because the depressors are for one-time use only, but totally can go in the recycle bin. And they're the same price as a flavored tongue depressor. So why not use one that lights up? And the kids think it's cool.
And it's so much more efficient. There have been so many times that I've had to use multiple tongue depressors during one exam because they get kind of ickier. And this one is just is so much easier. So this is what I use all the time. So anyway, what I noticed about her, just me seeing, you couldn't see it on the video, but I'm looking at her tonsils. I'm looking at the color of her pharynx. And then I also have a scale on this exam talking about, it's a Brodsky scale, which is basically a very consistent way to measure the size of the tonsils. So if you ever feel like you have to make a referral, or you might want to make a referral to an ENT, or even back to the pediatrician on a child, it's helpful if you can say, this is Brodsky 2. So those tonsils are taking up less than 25% of the pharynx, or, you know, they're not going beyond those fascial pillars. So that's just complicated way of describing the size of the tonsils.
But it's what all the otolaryngologists, ENTs, even the dentists want to know in our reports. So you actually have it mapped out right there so they know what to look for, which is great.
I don't know if you want to show that or if you
can.
Be
happy
show
to,
that.
yeah.
You can kind of see a diagram I've got there where you can actually see and refer to for a good visual on how to tell what Brodsky scale number to put down. So it just makes it easy.
Now, would you ever include this form in your report for any reason, or are you primarily pulling off of it and creating your report?
I'm always pulling, for my reports, I only pull off of it.
Okay.
And so I write narrative reports, but I always show the parents, this is what I'm seeing. And so these are really nice visuals too, to show parents, this is what it looks like, because sometimes it's hard, or you might be assessing a child when parents aren't there. Maybe you're at school.
Right.
So a lot of times it helps to have a visual.
Or only one parent's there.
Right, exactly.
Yeah. And people learn in different ways. So when we're just telling them something, if we can show them, if we can actually have a pictorial, that's a tremendous help.
Exactly. All right. How you doing?
Good.
Okay. And this is taking a lot longer than it normally would, just because we're describing a lot. But the next thing after I look at the pharynx and the tonsils, I want to look at the palate. So I have a whole section on what to look for regarding the hard palate and the soft palate. The first part is, all right, Lance, shall we ask you to stand up one last time?
Okay.
This is open up your mouth really good. See if I can get and look up a teeny bit. Say ah. I know, I keep slipping off. Oh, you can see that palate really good.
Wow.
And so what I'm looking at, and I can see this a lot better in person, I'm looking at if the palate is narrow, is it high? I'm looking at the soft palate and to see what it's moving. You can sit down.
Oh, okay.
I'm looking to see if there's good movement of the soft palate. And I have other things that you can check for too, as far as, are there any growths that you see? Is there a fistula? There are things that we got to look in that mouth to see if they are actually there. And sometimes I have kids who have come to me who have been described as hypernasal. They sound like they've got air coming out their nose. And an oral facial exam is what you need to do to look and to see if you see any structural reason that air is escaping into that nasal cavity during speech.
And just because we have a lot of parents joining us as well, can you explain what a fistula is and why it's so important to be able to light up that area?
A lot of times I know it occurs with corrected hard palates in children who were born with cleft palate. But it's basically a hole between the oral cavity and the nasal cavity where air is escaping through a hole in the hard palate. So that's essentially what a fistula is.
And especially for pediatric feeding, that's really, really important, because sometimes just the saliva, for example, I had a little boy a few years ago who had that little fistula. It was after a cleft palate repair, and it seemed not to be a big deal until he ate chocolate. And we all have to be able to eat chocolate. I mean, this is essential.
It's a must.
It's a must. And the saliva, the brown chocolate saliva, would would end up going up into his nose, and he didn't realize it, but it would drip.
Oh,
You know, and that's not a cool thing when you're in middle school,
it's
right?
not. It's not cute.
No. So a lot of this, again, we're looking at a structure, but we're trying to figure out how is it impacting function. And
Right.
many times function can impact other things in a child's life, like social skills, like pragmatics, like just have it,
Absolutely.
lunchtime, you know? So it's all tied together.
It is.
Mhm.
Absolutely.
Yeah.
So, and then other things too that I've noticed, especially regarding speech, is when I look in at the soft palate, if you find a bifid uvula, which basically looks like an upside down heart,
Yeah.
that little, hangy thing in the back of your throat as it hangs down, if it's bifid, so if it has like a little cleft in it, that can sometimes be associated with a submucosal cleft, which maybe it looks like everything is, all together as far as the soft palate goes. There's no obvious clefting. But if you hear a hypernasal vocal quality with a child and you see that bifid uvula and you suspect there's a submucous cleft, which just means there's not enough tissue that has come together, then you need to refer that child out to a craniofacial team, a cleft palate team, because the reason that they're hypernasal could very well be vivopharyngeal insufficiency, or basically what that means is that soft palate isn't able to reach the back of the throat to
Right.
block off the air from the nasal cavity.
And that can affect eating as well,
Oh,
and
sure,
feeding,
I bet.
especially breast and bottle feeding.
Yeah.
But for sure, as we start to move into solid foods, we really need to have that good closure of the soft palate up against the back of the throat,
For
so
sure.
kids can swallow safely and comfortably.
Definitely.
What else are we going to look at?
So the next thing I also like to look at, I think we kind of mentioned it, I just had a little section, I won't ask her to do it again, but I like them to phonate. So and I want to see to make sure that soft palate is moving medially, so kind of towards each other, and moving back. So that's what I'm looking for there. The next thing, we're going to look at lips. Let's see those
Yay.
lips.
I'll hold this up real quick
Yes.
just so that they can see. So we're now on the second page, is that right?
Yes.
So we're
this is
already on the second page. We're
page.
halfway through.
Yeah, and I'm even looking at the guidelines myself. Just sometimes I have to refer back to this, which is why I typed all this out, just so I can remind myself, because a lot of times we'll forget what exactly we're supposed to be looking at when we do these oral facial exams.
Yeah.
But I'm going to ask you,
Uh-huh.
Linz, to pucker your lips. How do you pucker your lips? And sometimes kids don't know what to do, or it's a weird thing to ask. So I'll say, okay, pretend you're going to give mom a kiss on the cheek. What would you do? There you go. Now, boys, maybe not so much. Sometimes they don't like doing that. So I'll say, can you pretend you're blowing bubbles? Oh, and look at that lip rounding. So I'm looking for good range of movement, good lip rounding for that. And then I'm also looking at, especially when we're talking about apraxia, is this a difficult thing for them to do this volitional movement without a model? So sometimes you'll have to show kids and they won't understand. So you'll have to say, okay, make your lips go like me, like that.
Sure.
And so they might need that. But if you say, okay, now can you do that yourself? Can you, make your lips nice and round by yourself? And if they're kind of, they're having a hard time figuring out. And
Yeah.
I've even had kids tell me, oh, that's hard. That's hard to do.
Yeah.
And then when they look in the mirror and they have a model, it's much, much better. But those are little red flags for me as far as apraxia goes.
Me too. I always compare it to dancing.
Yeah.
I'm a terrible dancer, but I still do it. I
Same.
love to dance. But you know how we all have our go-to move?
Oh, yeah. Yeah.
Well, that's the thing. I feel like a lot of children who do have that apraxia quality, wherever they are on the apraxia spectrum, they have their go-to moves with their mouth. And that can get in the way of learning to eat a variety of foods. They can become extremely picky eaters because they stick to the same types of foods because that works best with the way their mouth functions. And so a lot of what we do in speech and in feeding is help children learn a different dance step in their mouth.
A new motor plan.
A new motor plan.
It's a new motor plan,
Yeah.
right? Exactly. So if that's not a typical motor plan for that child, and you hear a lot of times children with non-speech oral apraxia just have a hard time with things like brushing their teeth and spitting and blowing bubbles and those kinds of things. So that's one of those ways on this assessment form that can kind of give you a bit of information as far as that goes.
Fabulous. So what's
All right.
next?
So the next thing is I'm going to ask you to smile for me. Can you smile really big? As big as you can.
Look right here, honey.
Look right there.
There you go.
Look at the camera. That's really good. So I'm looking for if there's any asymmetries. Sometimes I know you think of asymmetries as being, oh, well, maybe a side effect of having a stroke or something like that. And so as working with adults, that's what we always look for. However, I found it in kids too. And sometimes we're the first people that notice those little soft neurological signs.
Check out my asymmetry. Look at when I smile, one eye, look, this one closes more than the other.
Oh.
And I have a little bit of a crooked, my face is a little bit crooked. And as I'm getting older, it's getting more and more crooked. So why am I sharing that with you? Because A, you're my friend and I'm going to tell you these things about myself. But also we want to catch that really early in kids this age because their face is still forming.
Developing, right? Exactly right. So I'm looking for basically range of motion, symmetry, and then also strength. So what I will do, I'll take the throat scope out as well too. And sometimes now with adults, what I would do is I would put the tongue depressor between the lips and tell them to press your lips together, and I try to pull it out and tell them to keep it there. With kids, I found that all they want to do is use their teeth. So what I do just to gauge strength is pucker those lips again. And I'm just going to push. And see if you can push this away with your lips. Push it, push it, push it. Not with your neck, with your lips only. Can you do it? Push it. Good job. Good job. And so you can kind of see if those lips kind of relax as you're pushing against them, that's an indication of some muscle weakness there too. Then after I ask them to do both of those movements, so they should know what they are, I ask them to do them successively, rapidly, to see if there's any kind of coordination problem. So I want you to pucker those lips like you did for blowing bubbles. Look at the camera and then smile really big. Now pucker, smile, pucker, smile, pucker, smile. It gets harder when it gets funnier, doesn't it? But I'm looking for sometimes when you have those rapid successive movements, you notice some difficulty with motor planning too. So that kind of brings me to another point about any oral facial exam that you give. Make sure you do quite a few with some typical developing kids, because you want to know what atypical or, different structures look like before you start diagnosing kids with, well, this is muscle weakness or uncoordination. So make sure you give a bunch of these assessments as many times as you can to typically developing kids as well. All right, now the next one I'm going to do is, all right, Linz, we're going to ask you, you're going to look at the camera again. You're going to put a bunch of air in your mouth and you're going to hold it there. And I'm looking to see labial closure. Again, that's going to tell me if those lips are strong enough to keep the air in. And then also if I hear any air coming out of her nose, because I want to know that her soft palate is closing off well enough to keep air in her oral cavity. And I didn't hear any nasal air emission. I didn't see any air coming out of her lips. And you went, okay, do it again. Really big. Keep it in there. And I pushed hard. And she did great. Good job. So no issues there for her. Now the next thing I look at is the tongue. All right. So open your mouth really big. So I'm looking at all kinds of things. I'm looking at the color of the tongue. I'm looking for, are there any fasciculations or any kind of interesting movements of the tongue?
I'm going to look. You keep talking.
All right.
Yeah.
And then I'm looking at the size too. Can you look up there, honey? Straighten it out. Let's straighten her out a little bit. There we go. All right. Perfect.
How far out can you stick out your tongue? Not that it's that important, but
that's pretty far.
My mom is a speech therapist. You can just tell by her musculature.
Yeah. Lots of this kind of stuff at my house.
Yeah.
And so I'm also looking too to see if there's any kind of heart. You might have heard of the heart shape, tip of the tongue. If they stick their tongue out, that if their little strip of tissue under their tongue is a little bit small or short, you might find like a little heart-shaped indentation at the tip of the tongue as well.
That's something we talk a lot about in my 2-day course. I have a whole 2-hour module on tongue and lip ties, and I have a lot of information on that on my website. That is a very different type of exam. And what I'll do is I'll also include a link when we're all done here so that you can go and learn how to do that as well. But I love using a throat scope for that initial screening. You can definitely get a quick visual to determine if that frenum is a little bit tight. Is it posterior? Is it embedded? Is it submucosal? And as well as I really like to use these to lift the lip up and see underneath, especially to see if any food is pocketing up there. But that's a very different type of exam than what we're covering tonight.
Yeah, and that's another thing I should mention too. This basically, all the information that you'll get from this assessment, the oral facial assessment, I look at, since I'm a speech sound disorder specialist, this is what I do at my practice. I'm looking at in terms of how are they able to produce particular sounds.
Right.
And so that is what the purpose of this particular assessment is. I'm glad you mentioned that about feeding. Okay, so the next thing I'm going to have you do, you're going to stick out your tongue really, really far. So we're looking at range of motion, which is awesome. And then we're going to look at strength too. So I'm going to put this out in front of your tongue. Okay. And I want you to use your tongue, only your tongue, not your neck, not your head. And you're going to push this away. All right. Push it away. Push it away. Ooh, nice job. I know, it's a little slippery. And so I'm looking to see if her tongue has good strength, and it does. And then the next thing I'm going to ask you to do is open your mouth really, really big, and I'll try to shine this in there as best I can. And put your tongue all the way back in your throat. Can you put it all the way back? All right, all the way back. Ooh, nice job. I don't know if you can see that, but good. So I'm looking for any deviations.
Can you stand up for this one,
do that.
babe? Yeah.
Perfect. All right, so let's
There's
see.
your audience right there. There you go.
Can you see? I'm trying to shine. Okay, good. Perfect.
Mhm.
So I'm looking to see that the movement is symmetrical. There are no deviations. And then if there are any really significant restrictions under that tongue too, and I don't see any. So you're good. Good job. And the next thing we're going to do is I'm going to have her stick her tongue out and then move it side to side to see if there's any limitations as far as range of motion as well. You ready? You're going to stick it out, and you're going to move to this side. Which side? The other right. Good job. Left, other right, left. Good job. And what I like to look at as well, especially with children who have a suspected speech sound disorder, because you may not know yet because maybe you haven't done your articulation assessment, is to see if that jaw is pretty stable when that tongue is moving. Because if I've had kids who are doing one of these,
Yeah.
and they cannot separate the tongue from the jaw as they're moving it. And so a lot of times my kids who have those pervasive R errors or lisping or, some specific articulation issues, I may incorporate differentiating the tongue movement from the jaw movement into speech therapy too, because you have to do that for those sounds.
You do, and you actually have to do it for eating too. That disassociation, we call it dissociation,
Right.
we call it, where the jaw and
Yep.
the tongue actually move. They can move in different directions even, and really have two very different motor patterns, or they can go in more parallel movement in order to help that child eat a variety of foods. But being able to separate those out and bring them back together when you need to is really, really important. And a lot of
Absolutely.
kids can't.
Very true. And so the next thing we're going to do is, this is just another range. Oh, I actually forgot to do strength. So I also look at how strong the child is moving the tongue in one direction versus the other. All right, so you're going to stick your tongue out. What side do you want to move it to? Okay, now do it. Move it up over to this side. I'm going to push it. Don't move your tongue. Keep it still. Don't move it. Good job. Now this side. Don't move it. Don't make me move it. And I'm looking to see if there's any asymmetry with strength as well too, because again, sometimes we can see some soft neurological signs before other professionals do. And so that's the asymmetry of strength is one thing to look for too.
I have a question. Are you doing this when a child comes in and there's some concern about possibly a sound disorder, et cetera? Are you doing this right away, or are you doing your other screening and testing first? Or where
That's a
does
great
this
question.
come in during your assessment?
It depends on how comfortable the child is with you. I kind of read the room and see if they're really outgoing and they're willing to cooperate. A lot of times I'll do this first. But sometimes, since you're kind of invading personal space, oftentimes I will leave this for the very last part of the assessment. Or if I have a really apprehensive child, we'll wait until we've established better rapport. So it just kind of depends. I like to do it first thing, but if I can't, I can't.
Either way, within your hour or so assessment, you're going to get the information.
Yeah, and a lot of times, sometimes you may just have to do like, oh my goodness, what do we, and you're going to get creative ways to make them open their mouth if they don't want to do it with a tongue depressor. Although I have to say, the wooden tongue depressors always kind of made kids nervous because it's a doctor's office. And so I have found out, I've heard other SLPs call this the lightsaber too.
Always.
Oh my gosh. And I know. Doesn't it look like a lightsaber? Yeah, totally does.
It's just so fun.
It is. And so what I will do to get kids to cooperate with me is bring this out. I mean, all of a sudden it's like, what is that contraption? How cool. Or I will even give it to the child, and we'll get a puppet out. We'll let them do it. And so if you need to get creative with getting the kids to cooperate, that's one way to do it too.
And I noticed someone already had a question about younger children.
Mhm.
Any tips on how to adapt this for a little bit younger child, more preschool age?
Yeah, I would say so. In my practice, I usually see kids at around 3.
Mm-hmm.
And past, at about 3 is usually when you can start to get them to really cooperate well. So it's going to be tricky with really younger ones. Although sometimes you may not be able to get all of these little volitional movements, like, okay, move your tongue side to side, now push against the tongue depressor.
Yeah.
But you can maybe through play or some silly movements and silly games, turn taking, having them imitate some silly movements with your mouth, you can at least get an idea for each of these areas on the oral facial exam. So you might have to be creative. I did have Carrie Ebert again. I'm going to mention her again.
Love Carrie.
She's great. She did mention to me just when we were at the Apraxia Kids Conference last month, I think. She said one great way is to get one of those big exercise balls.
Mm-hmm.
When you're playing with kids on their back and you roll them back, that mouth automatically opens up. So you can at least get a look at that palate, at the teeth, hope maybe even at the tonsils if they can open wide enough.
Absolutely. You can even, if you have a clinic setting, put a mirror up on your ceiling, because when you go back, you can actually see the kids laughing and you can get a pretty good visual of that.
That's a great idea.
Yeah.
I may have to take that idea. That's a good idea.
Another one too that I find really helpful, especially for my kids in feeding, is, and the younger ones we're talking about right now, I'll put them on my lap and then I come around with my throat scope and the mirror is in front. And they're sort of like, whoa, you know how kids just get mesmerized looking into a mirror. And I can come around, and just the fact that their mouth is just being lit up, it's just fascinating to them.
I've even had kids on mom's lap and lay back so that I can kind of peek over them, over the top of them and see what I can see. Yeah. So those are some ideas there.
So we just have a couple more left.
Yeah, just a couple more. Let me see. I have to remember where we left off. We did right to left. And then I always do up. Try to touch that nose, stick that tongue out, touch that nose. Nice movement. Can you touch your chin down there? Awesome, good. And again, you're looking for range of motion. I'm not looking for strength necessarily as far as speech goes for those, a little wet, for those movements, but I am looking to see if there's any groping or any difficulty moving that tongue. And then the last task is sticking that tongue out and moving it side to side quickly. Can you do that? Nice job. And again, this is really telling too if they need that jaw, if that jaw is not dissociated from the tongue at all. So she did good. Nice job.
That was really good. Really good, Lindsay.
And then the last, that's the last actually motor task. The next one is, now SLPs know what this is, Diadochokinetic rate. And basically it's just rapid succession production of phonemes or syllables, basically. Yeah. And so I have a whole chart here. I don't know if you can see that.
Here, let me hold that
up. And it tells you what syllables to assess, and then how to time out those syllables. So like, let me hear pop, 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 pop. Can you do it really quick? Keep going. Pop, 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 pop. Good job. Now do ta, 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 ta. Ka, 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 ka. Now here's the tricky part. So basically with those, what I would do is I set my iPhone on a stopwatch, and I press, when they start, I press go, and then I count 10, or 20. It might be 20 for, I think it's 20 for those individual syllables. And then I press stop when I get to 20, and I see, and then you do that several times and you take an average, and then you see, and you can compare with what typical kids, how the coordination for those.
And you're going to record that on your form.
And you record it all on the form. And then although the one that is most telling is when you're putting all three of those together. So pa, ta, ka. You ready? You want to try it? So we're going to say pataka, pataka, pataka. Try that for me.
Pataka, pataka, pataka.
Now, let's try this. Patika, 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 patika.
Pataka, pataka.
see, this is why though you do it with typical developing children, because you want to know, ooh, oh no, they're having trouble with that one. Typical developing children can have trouble with this. So you want to know what typical sounds like and looks like. All right, let's try it again. You ready? Let's try to do 10. Potock, 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 and you're going to keep
All
going.
right. Potock, 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 Potock.
Keep going.
Potock, 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 Potock.
Perfect. Good job. Awesome. Okay,
That's
so
awesome. You're amazing. Amazing.
and you're going to have to do that a few times and get some practice, but those give you some really good measurements too.
I just love this because it, it really gives parents a chance to understand what we look at and how it eventually relates to function.
Right.
We're just not just looking in their mouths and saying, say ah. So yeah, this is so good.
Thanks. Yeah, it's really, one thing too that I did after that is, I know sometimes it's hard to figure out, okay, that's great. I circled a couple things I was seeing that don't look typical to me. Now what? So that's what I have at the bottom of here, of basically after that Diadochokinetic, and you can maybe hold
Yeah,
that
happy
so
to.
you can see. Okay, if you see these 4 things, then maybe consider a referral to this specialist. Or if you see these 5 things, then you might want to refer here. And sometimes we do need to make appropriate referrals. And so I have made referrals back to the pediatrician if I notice some soft neurological signs. And I have had kids who have actually gone to be diagnosed with certain genetic conditions. And we're the first people that find this sometimes.
It's a little bit hard to see, you guys, but this is my favorite part of the form because you literally have, I think almost 20 questions here that are meant to help you brainstorm about what could be going on with this little pumpkin and how can I be of help?
Right.
Where should I refer this child? And I think especially new graduates, that's challenging. But for me as well, primarily doing feeding, I love this form because I still want to go through it with all my kids so that I know to refer to someone like you or a specialist like an otolaryngologist, et cetera, et cetera.
Right.
So,
for sure.
And I also noticed that the very last page is nothing but references. So you have some good references to back up this form.